Very good evening, one and all, and warm welcome. We have gathered here for an academic feast that is to follow. As per latest study published in Lancet, India has 212 million patients living with diabetes, which accounts for 26% of global burden. This is an alarming call to prevent diabetes and improve diabetes care. Recently, 68th EASD annual meeting was held in Spain to share some of the key clinical findings published and its implication in clinical practice. We have eminent leaders and experts from the field with us. And I have the honor of introducing our key moderator for the day, Dr. Arpan Dev Bhattacharya. Sir is consultant of diabetes and endocrinology at Manipal Hospital, Bengaluru. Sir has authored 120 peer-reviewed publications in reputed national and international journals. Sir is also member of esteemed organizations like ESI, British Diabetic Association, Society of Endocrinology UK, RSSDI, and Indian Thyroid Society. Throughout his illustrious career, Sir has received numerous accolades and honors. With this, we welcome our moderator, and I now hand over to Sir.
Thanks, Dr. Charmi. Good evening, everybody. Good afternoon to Dr. Antonio. And it's my pleasure and prevalence here that I am here to listen. Just a bit, one or two words before we start. So we are going to listen from horse's mouth about the topic on holistic approach for cardio-renal metabolic risk management in diabetes and focusing on gliptin and gliflozin combination. Now, I distinctly remember when in our training time, whenever we are seeing people of diabetes, our concern was a diabetes control, although the target was not very well defined. And we are all concerned about the acute complication like a diabetic ketoacidosis, hypoglycemia, or hyperosmolar coma infection. We had no idea about what other things diabetes can do. End of the 80s, 1980s, we started learning that type 2 diabetes is the cardiac risk equivalent. And beginning of this millennium, we are very much aware of the heart failure. There's a big problem for people with the diabetes. So obviously, our focus completely changed from only glycemic control, that is a glucocentric approach, to a organ protection control. Because at the end of the day, 2/3 of the people with the type 2 diabetes will go up, leaving us, or atherosclerotic cardiovascular disease and heart failure. And it's my pleasure now to listen to this topic, how the current molecules can help us in treating our patients better. It's my pleasure to introduce Professor Antonio, whom I have seen this year's EASD in Madrid, myself physically, although I don't know whether you remember me or not, is a research consultant in this institute, which leads at IRCCS Multimedia in Milan, in Italy, and he is the chair of the Diabetes and Cardiovascular Disease Study Group of EASD, member of the IDF European Board 2009 to 12, and a consultant in EU Commission for Diabetes as a model of chronic care management. He is also the associate editor for Diabetes Care and Diabetes Medicine, editor-in-chief in Diabetes Research and Clinical Practice, editorial board member of cardiovascular diabetology, and also on the key board member for 2019 ESC guideline for diabetes, pre-diabetes, and cardiovascular disease. He is, believe me, more than 500 original papers and multiple book chapters. We will be waiting to hear from you, sir. To you, Dr. Antonio.
Good evening, everybody, and thank you again for inviting me to share some news coming from EASD, and not only related to gliptin and gliflozin, but just a few studies, also a few studies which are very interesting. Because I know very well my colleagues in India now, because in the last year I was more in India than at my country, I can say. So I think that they can find this also of interest. So let me start sharing I think that you can see now my presentation. So let's start with some key highlights coming from the EASD. And particularly, there were some very interesting studies regarding fine renown, which is a mineral corticoid receptor antagonist, which is very interesting as molecules because it's working on this system. So it seems to be seems to integrate other possible therapies in diabetes and non-diabetes. And what it in past has been already shown that it works very well in protecting the kidney in diabetes. But you see here that, for example, this was the first demonstration that these molecules is working also in protecting heart failure from the risk of heart failure in diabetes. It mild or preserved ejection fraction, which we know are the most common in diabetes. You see here the design of the study with the firenone was tested in different doses and compared with the placebo. And okay, you see here the outcome that there was a interesting, important improvement of the not only of the situation of heart failure, but something and it was independent from the diabetes status, but also because this study has been performed in people with diabetes and without diabetes, it was coming out an interesting data, which is of course preliminary, but it needs to be confirmed. But it has been shown a significant reduction of new cases of diabetes of about 24%. So very active treatment. So in conclusion, in this study, that we can say that among patients with heart failure and mild or reduced or preserved ejection fraction, fine Renault reduced the risk of a primary composite outcome of cardiovascular death and total heart failure events, and reduced total heart failure events. And this was consistent across any specified subgroups, in particular including people with or without diabetes. Hyperkalemia, of course, was more common, but anyhow was not rising a serious issue. And finally, this new evidence that firenone can reduce the risk of new onset diabetes. Again, about the firenone, we have something interesting because, of course, one of the question is, okay, what happens if you combine with another drug like semaglutide, which we know is very active in preserving cardiovascular disease, but also, you know, from recent trials to protect the kidney. Well, in this trial, you see here the design. It was the superiority of a semaglutide versus placebo was confirmed in terms of kidney and cardiovascular mortality. But we can say that this was independent by the presence of having or not an MRN, a mineral corticoid receptor agonist in the background. So this is a good news because if you look at the possible conclusion, not only we can confirm that the flow trial has demonstrated the power of semaglutide in improving the kidney risk. But like this study confirms that if you have a mineralocorticoid in background, it works anyhow. It works, and this is really a good news because it is possible that you can combine it to have more power in protecting the kidney of the people. But this is also very interesting and more specific for India, because in this study, there was what about the specific management approach in young Indians versus more aged white population? And you see here that in this UK biobank, the risk for cardiovascular disease in the diabetes in South Asian and Europeans was quite different, more pronounced in people with some Asian of some Asian origin, and also was emerging more early in Indian people than in Caucasians. So this suggests some metabolic paradox. The first, that not all Indians who have a BMI labeled as healthy are at their most healthy weight. More fat, but very little muscle in India. Indians are hyperreactors. Asians are at increased risk of having heart rate versus Caucasians. Also, there is a glucose paradox. Young onset diabetes in Asian Indians associated with lower measured and genetically determined beta cell function, and subgroup of patients in India reveal insulin deficiency as major driver, more than insulin resistance. And finally, an heterogenic dyslipidemia, because about 3 or 4 patients suffer from heterogenic dyslipidemia, which very often is not so frequent in Caucasian with diabetes. So you see that to have an holistic cardiorenal metabolic risk management in Indians means that this must start as early as possible, and even at every stage works. But of course, the prevention is very important, because you can favor a regression of some situations, some comorbidities, that if you delay, probably there is no time to be successful. And this is a specific for Indian people. And we have this recommendation coming from RSSDI, that is Indian Scientific Societies, which underlines that in type 2 diabetes mellitus in young adolescents, there is a risk-based screening for prediabetes, and all type 2 diabetes should be considered in asymptomatic children and adolescents, performed after puberty or after 10 years of age, whichever occurs earlier. If tests are normal, repeated testing at a minimum of a 3-year intervals, or more frequently if BMI increases. So it's really underlying an alarming situation in the young Indian population. Fasting plasma glucose, 2-hour plasma glucose during a 7-gram oral glucose tolerance test at A1C can be used to test for prediabetes or diabetes in children and adolescents. Panel of pancreatic autoantibodies should be tested to exclude the possibility of autoimmune type 1 diabetes, and the patient should be evaluated for monogenic form of diabetes or pancreatic diabetes if clinically indicated. So the second part is more specific, but I think that what is really important is the first part, because underlying high risk for young people of India of having diabetes, and this needs to be found out as soon as possible. Again, you see some recommendations regarding lifestyle and nutrition, and you see that nutritional counseling might be provided by healthcare provided, training in nutrition therapy, not necessarily by an accredited dietitian nutritionist. Anyhow, you need somebody who is an expert. Overall, reduce consumption of a simple carbohydrate, sugar, fried foods, and high consumption of complex carbohydrates with high protein intake are recommended. And during my multiple trips in India, I say that this is very, very important, considering the kind of diet typically of India. Salt intake should be in moderation. Encourage increased duration and frequency of physical activity where needed. A mass awareness campaign for healthy diet and lifestyle should be conducted. So it's also very important to intervene at young age to change the lifestyle and the kind of diet particularly. But there is another point very important. When to initiate a combination therapy, what to do, what are recommending the last, let's say, guidelines. So for example, early combination therapy the IADA suggests that an early combination therapy can be considered in same patients at the treatment initiation to extend the time to treatment failure, level A recommendation. The AACA association suggests that an entry A1C higher than 9% and or a 1.5% above target, in this case, should consider dual or triple therapy, and the RSSDI 2022 suggested consider the initiating the combination therapies. The A1C is higher than 1.5% above the target. I say that I had a recent tour in India presenting, pre-launching, let's say, some chapters of the new IDF guidelines, and we moved ahead because in the recommendation, we are not putting any, let's say, threshold to start with the combination therapy. But we recommend that in some cases, it's useful to start directly at the diagnosis with a combination therapy. So in conclusion, Asian patients with type 2 diabetes have demonstrated a faster progression of the disease, thus demanding an early aggressive approach to slow the disease progression. Early combination therapy in type 2 patients has demonstrated greater durability of A1C lowering, both in clinical trials and in the real-world setting. Due to the loss of a patent of several drugs, Asian countries such as India have several dual triple combination to aggressively manage A1C reduction. And this is a really advantage for this country, which can count on drugs like, for example, the SGLT2 inhibitors, which are cheaper than in other continents or countries. But let's move to latest data on SGLT2 inhibitors. At EASD was presented the impact on the dapagliflozin on some on the outcomes after acute MI according to baseline glycemic status and body mass index. This was a DAPA-MI sub-studies. You see that more than 3,000, almost 3,500 people met the inclusion criteria, and the participants were categorized according to their baseline A1C as normoglycemic, A1C less than 5.7%, or having prediabetes between A1C between 5.7 and 6.5%, or higher, or if having an A1C higher than 6%, 6.5%, they were excluded. So you see here the design of the study. And what was really interesting was the incidence of, because people with over diabetes were excluded, the incidence of a new onset type 2 diabetes was lower with dapagliflozin than placebo among all patients, meaning patients with prediabetes and with obesity. So any person at risk of developing diabetes treated with dapagliflozin had less chance to develop diabetes. And regarding the risk for symptoms of class 2 and 4, they occur less frequently in the dapagliflozin group than the placebo among all patients. All patients with prediabetes and patients with obesity. So in these categories, we see there is a very good efficacy of dapagliflozin. Look, we are speaking about people without diabetes, just with the prediabetes or obese, and with a myocardial infarction. So in conclusion, dapagliflozin compared with the placebo reduced the occurrence of new onset diabetes mellitus following a myocardial infarction, regardless of baseline A1C or BMI, and with a greater absolute risk reduction in those with prediabetes or obesity. Dapagliflozin had a greater beneficial effect on heart failure symptoms in those with, again, with prediabetes versus normal glycemia. Also, these data are interesting. The effect of dapagliflozin on hepatic fibrosis and steatosis in type 2 diabetes with non-alcoholic fatty liver disease. You know, this is an emerging comorbidity which is present in a huge number of people with diabetes or obesity. And this is the one of the most, today is defined, is now known as EASD, MASD. Is the most common cause of liver dysfunction in the world, accounting for about between 20 and 40% of the global prevalence. And among patients with type 2 diabetes mellitus, the 40-60% have this MLSD MASD. And SGLT2 are an excellent group of drugs that haven't shown good results in decreasing the blood sugar, also having a good cardiac effect. So also there is an effect on weight loss. But the possibility of impacting on the liver fibrosis or steatosis has been not extensively studied in humans until the presentation of this study. And this was the aim of this research. This is the study design, including a small number with all more than 32 consecutive patients of type 2 diabetes mellitus a fatty liver. These patients were treated with the dapagliflozin 10 milligrams per day on top of dietary and lifestyle modification for 6 months. All patients were assessed for anthropometric, biochemical, abdominal ultrasonography, and transient elastography at baseline and followed up at 6 months and 6 months. At the primary endpoint was the change in hepatic steatosis and fibrosis, and there was, of course, a significant improvement of glycemic markers, but particularly interesting that the markers, the presence of hepatic steatosis, of hepatic fibrosis was dramatically reduced. So even it's a small number, but this study performed very well. We have a signals that dapagliflozin helps improving the mouth in people with these complications. So interesting news for the possible treatment. I say why it is interesting news, because you know there are already some specific drugs approved by FDA for the treatment of the mouth. But anyhow, because the SGLT2 are widely used in diabetes, this means that at the same time, not only you can tackle glycemia, not only you can tackle the risk of a cardiorenal risk, but you keep on board also the possible protection of the liver. And also this other aspect of using an SGLT2 inhibitor deserves attention, because this study was looking specifically at the possible protection in people with atrial fibrillation and type 2 diabetes. You know, atrial fibrillation is unfortunately an event which can predispose to very serious complications. You see here that more than 4,000 people were included in this study with type 2 diabetes and atrial fibrillation. They were all newly prescribed SGLT2 inhibitors or DPP4 inhibitors, and then they were matched by propensity score in a 1-to ratio, and the median follow-up was 31 months. And the end point was the composite outcome of either heart failure hospitalization or death, and there was found a lower risk of hospitalization or heart failure or death in people treated with an SGLT2, less risk for CV mortality, significantly lower risk of a primary outcome from now 90 days after initiating the drug to the 3rd year. So very early effect, which we know, we learn in the case we use an SGLT2, there is a very early effect in protecting kidney and the heart. This was confirmed in this study, even in presence of atrial fibrillation. So in this nationwide cohort of patients with type 2 diabetes and atrial fibrillation, SGLT2 inhibitors showed a lower risk of mortality compared to DPP4 inhibitors. This may support the use of SGLT2 inhibitors as first-line anti-diabetic medication in patients with type 2 diabetes and atrial fibrillation to prevent adverse outcomes. Let's move to one of the interesting topic, which is in India, I know is particularly interesting. What happens if you combine sitagliptin and dapagliflozin, which new evidence we have? You know that probably is less recognized some effect beyond the cardiovascular effect of dapagliflozin. If you look at more modern approach in looking at the management of hyperglycemia, in the years we learned that A1C is not enough. We learn in years that postprandial hyperglycemia, short-term and long-term glucose variability, and the more recently time in range are all aspects of glucose management, which is very relevant for the optimal glucose control, but also for prevention, particularly cardiovascular disease prevention. And this is why some years ago I suggested that like the Vitruvian Man, which is this with the drawing coming from Leonardo da Vinci, which is a very, I think, famous genius, Italian genius. This was representing the perfect measures, the drawing of Da Vinci. And so I suggested that using this as a scheme, you can have a perfect management of hyperglycemia today if you take all these aspects of glycemic control. And it's really worth of interest to know that dapagliflozin, according to the available literature, is able to control, to improve all these aspects, modern aspects of glucose management. So this is an extra benefit if we use dapagliflozin, because not only you, of course, reduce A1C, of course, you protect the kidney, you protect the heart, maybe you protect the liver, but you have a more important protection in terms that you can better control all the aspects of glucose, of the hyperglycemia. And also, there is something that we need to underline about one aspect of specific of diabetes management, which is the legacy effect of hyperglycemia. You know that this was a phenomenon first described in the edict, DCCT edict, and then confirmed in the UK PDS, that what we do at the beginning in terms of glycemic control lasts for many, many years. And the concept of metabolic memory is that we have studies supporting that there is a long-term influence of early metabolic control on the clinical outcome, meaning that an early glycemic environment is remembered in target organs, in all the organs. What is important is that from the UK PDS, this benefit of early aggressive control has been confirmed for even for 24 years. You see, this is a study published a few months ago, and in Lancet, the UK post-hoc analysis, a follow-up of the UK PDS demonstrated that after 24 years, you still have a benefit in people who were intensively treated from the beginning. So we were wondering, but in UK PDS, only insulin, metformin, and sulfonylureas were available. So what happens now that SGLT2 are also available for the management of diabetes? Using the huge database from Italy, we have more than 1.5 million people observed for more than 20 years. We were selecting people with diabetes, type 2 diabetes, without any complication. And we check what happens if we introduce an SGLT2 within 1 year, 2 years, or 3 years in terms of composite outcome of myocardial infarction, stroke, and coronary or peripheral revascularization and coronary or peripheral bypass. We confirm the presence of the legacy of metabolic memory, but this was very important. We were able to show that if you introduce an SGLT2 within 2 years from the diagnosis in people without complications, you avoid the appearance of the metabolic memory. And what is more important is that this is independent, that if the people are or not at target. You see that we found that the people were protecting against metabolic memory if the A1C remain higher than 8%. This, of course, suggests its conclusion that a wider and early use of SGLT2 inhibitors should be very, very helpful in prevent cardiovascular and the complication induced by the metabolic memory. And this has been confirmed, let's say, we had the opportunity to discuss in two commentaries, which are now published, supporting that the possible benefit of an early use of SGLT2 inhibitors in diabetes management, first for the action of a different aspect of glucose control, and then for the specific action in protecting against the metabolic memory. So, good news for our patients because we have good tools to prevent the complications. How this can work? You know that the metabolic memory is linked to the free radicals of a generation, which at the end of the day is inducing epigenetic change in at the DNA level. And now we know very well that the SGLT2 receptor is a key player in modulating intracellular protection. So when you put an SGLT2 in the system, you increase the defense of any tissue against free radicals, and this explains why you are so good in protecting the cells. So what is new? Also, sitagliptin is helping in reducing this against the multiple modern aspect of hyperglycemia. So DAPA and SITA, they can co-work in improving this global aspect of postprandial glycemic control. And if you remember from the verify that when you start combining, in this case, metformin plus vildagliptin, and use from the beginning, and you compare this combination against the single use of each drug, the beta cells are longer protected. But this is not true only for the vildagliptin. We have evidence also for sitagliptin, so it means that probably is a class effect. So this is also important because it suggests that the DPP-4 inhibitors are really protecting beta cells if early introduced in the treatment of diabetes. So what can we do differently? This is the ADA recommendation how to treat diabetes. You know, on the one side, the kidney and the heart are specifically focused in terms of what to do using GLP-1 on heart failure. On the other side, there is the recommendation on how to control glycemia. So my suggestion is, as our chairman underlined, it's time to move from simple glucocentric approach and to have an approach, in my opinion, which can harmonize a gluco and cardiocentric protection of the people with diabetes. In the same person, we do not have only cardiovascular risk, but also we have hyperglycemia, and we need to treat both. So I will say that a more modern approach should be, of course, to protect, to pay attention to cardiovascular and kidney risk, but also to glycemic control in terms of what means modern glycemic control. And if you put together metformin, dapagliflozin, and sitagliptin, you take all these two conditions, but also you are able to protect from the complications because you can avoid the legacy effect of hyperglycemia and do improve the durability of glycemic control. So this is a more modern approach, which is already underlined with the new IDF recommendation of a clinical practice which were presented a few weeks ago in India. Thank you very much.
Right. Thank you very much, Dr. Antonio. It's wonderful to listen to you. And really, we need to move in our clinical practice from glucocentric to organ protective mode, is gluco, cardio, renal, metabolic, all the parameters. Now, we actually, I don't know about Italy, we have a fixed dose combination available for metformin, gliptin and gliflozin. So that's quite a bit advantage that we can use a less number of pills so that the compliance becomes better and the pill burden becomes less.
Yes, it's a concept that already is known in other kind of therapies. No, in hypertension we have already fixed combination, and also for diabetes, probably is not so well known that the first country in the world which were using a fixed combination was Italy. I'm speaking 80s, and there was this. We were criticized by anybody in the world because we were using a fixed combination. But now there is a clear direction in this way. There is clearly this direction is very important because it improves the compliance. Because unfortunately, people with diabetes they need a lot of pills, a
Yes,
lot of
correct.
drugs, and try to get to just remember to get, let's say, 10 pills a day. When, how? So the fixed combination are very helpful, and we have studies in other settings which are demonstrating that use of a fixed combination improves a lot of the compliance.
Right, absolutely right. I totally agree. This is exactly our experience. Now, there are certain, now, one side, the gliflozin, SGLT inhibitor, really producing a miracle. So, whichever organ you go, they are doing better. I remember beginning of this millennium when you started doing the clinical trial with CANA, EMPA, DAPA, people's concern was there. We are doing a bit glucose wastage. What will happen? But after publication of the few trials from say 2009 onward, it was completely whitewashed our clinical management. Now from everywhere, from atherosclerotic cardiovascular disease to heart failure to kidney, then plus all the metabolic parameter like an MASLD, we are really pleased to see. And the time actually has come when we need not tell that what is the indication of gliflozin, but we need to tell that why you are not giving gliflozin if somebody with a type 2 diabetes you are not using. So you'll have to really justify it.
I completely agree. I completely agree. My position is that an SGLT2 must be started at the diagnosis in any people with diabetes because there is a so huge advantage. And you cannot forget, they also are very good in lowering glucose because in the last years we were so paying so much attention to the other aspect, no cardiorenal benefit, now liver protection, but they also work very well in reducing hyperglycemia. So according to all the evidence are accumulating, we need to start an SGLT2, in my opinion, from the beginning. And this is also present in the recent, let's say, recommendation of IDF, because we are now lucky that in many countries, SGLT2 are relatively cheap, at least are affordable by many people, which was not in the possible in the past.
Right. Now, can I just clarify some of the doubts? Now, one question or some data we see quite often that if you combine a gliflozin and gliptin, your chance of genital myocardial infection becomes less. Now, first question is, do you agree with this? Second question, if you agree, what is the mechanism?
Probably the inhibition of the DPP4 can play a role because the or maybe it's simply because you get a better control, less glucose in the urine. Because at the end of the day, the infection are related to the glucose in the urine, which are a very good problem for the bacteria. So probably because combining both, you get a better improvement, meaning that the glucose is reduced not only because of the action of the SGLT2, but also for the action of the DPP4 inhibitors. You find less glucose in the urine, and then you have a less possibility of bacteria growing. But I want to underline that the side effect of infection, particularly genital infection, can be easily counteracted by hygiene. It's not something that is related to the drug. It's simply because the urine is plenty of sugar, and you need to pay more attention to hygiene.
And also, you think this genital mycotic infection is prevalence is different part of the world differently, particularly for hot and humid country, they are more common than compared to the cold country?
I think that this is can make a difference in terms of what is the attitude. Because, for example, in some countries, in Muslim countries, where the religion is suggesting the specific hygiene, this kind of a complication is almost absent, meaning that, of course, in very humid countries like India, in some periods, this is very helpful for bacteria to grow. So, meaning that unfortunately you have to pay more attention in hygiene. But is this the clue? You do not need to, particularly, you do not need to stop the drug because it's not guilty. The drug is, let's say, can be solved the problem or prevented.
Yeah, that's thank you. So another point, whenever most of the time we face the problem. For example, we are using dapagliflozin. Do you see any difference between 5 and 10 milligrams? Should we consider straight going to 10 milligram for everybody? Forget about 5 milligram.
Let's say that the most interesting results have been reached with the 10. So at the end of the day, this is the dose which is. But as a doctor, you can start with 5 and see what happens. Even very often in the fixed combination, you find 5 and then times a day you reach 10. But this is handled by the doctors, meaning that you have to see which works well. 5 works, okay. Otherwise, you have the chance to go to increase to 10.
Right. There's some of the audience question I want to ask one or two from them. There are plenty. So one person is asking about the bone health with the gliptin, particularly giving reference that we had some doubt about canagliflozin increasing risk of amputation, osteoporosis, fracture. What happened to the gliptin and the bone health? Is
So
anything to worry about?
If we speak about the Cana, these doubts are over from some years because the data were coming only out from only one trial, but it was not clear at the beginning that the rate of this amputation was very low in the placebo group compared to any other trial. So it disappeared because there was and any other trial was not confirming, even specifically performed. So I think that this occurs in people, honestly, in people with peripheral artery disease. You can use an SGLT2, but you have to pay attention to what happens to blood pressure, because the risk is that you can have some reduction of the flux. Because if you lower blood pressure, meaning, for example, you treat already for blood hypertension, you introduce an SGLT2 inhibitor. Usually, you have an extra reduction of blood pressure, but if you have a peripheral artery disease, this is not good because you reduce the flux of blood. So, in these persons, you can use, but you must be very careful and maybe to reduce the risk of hypertensive therapy. About DPP4 inhibitors, I think that they are so safe, honestly. I don't think that we are anymore speaking about these problems. I was involved in long term when they were entering in the market. In Italy, we were obliged to have a follow-up or what was happening using NDPP4 inhibitors. At the end, after 5 years, nothing was happening in any kind of possible complication. So we have a direct experience that there is no problem.
Okay, thank you very much. So I have another important questions here to ask you. So now we are talking about gliptin gliflozin combination therapy. Now we have a lot of benefit, kidney benefit, MASLD benefit. Now, if you have to choose between these two,
sorry,
which one you will go for?
You should repeat because I lost the connection, but we were fraud.
Yeah. So for the combination therapy, one hand we have a gliptin and gliflozin, and now we have lot of data with the semaglutide, injectable semaglutide, on glycemic control, on weight benefit, on kidney benefit, cardiac benefit, MASLD benefit. Now, if you are allowed to choose a combination therapy, which one will go first, gliptin gliflozin or gliflozin and GLP-1 receptor analog?
First of all, we do not have specific data on SEMA and SGLT2. They are coming. But my question is something else. How long can you keep the treatment? If you start with gliflozin and gliptin, you can keep this treatment almost for the life, meaning that until you have a good control, it's okay. But when you use an GLP-1 receptor agonist, you cannot use it for the life. But it's not Antonio who says this, are data. We got a survey from the United States, and after 2 years, only 1 on 4 people are continuing, and not for the shortage, but for the side effects. Because, and also, you know, in UK, semaglutide is reimbursed only for 2 years, because in Europe, the drugs are reimbursed. Because after 2 years, for the NHS, that is the system, the British system, they see that there is not an improvement of the situation. Why? Because people, at the end of the day, they want also to live. And when you have a GLP-1 on board, the side effects are really conditioning your quality of life. You have a nausea, you do not like to eat, you can have a gastroparesis. So there are serious, but also the quality of life that for the short term can be tolerated if you have the aim to weight reduction. But to keep forever, honestly, and when you stop, you regain weight and the situation is worsened. So I think that there is no doubt that the gliflozin combination is preferable. The semaglutide or any other GLP-1, of course, is very helpful, but you have to understand for who, for how long you need this treatment, because it cannot be continued forever.
I think this is a very, very practical answer. I completely agree with that. Thank you very much, Dr. Antonio. It's wonderful to listen to you, and thank you very much for clarifying our questions from our speakers and also from our audience and also from myself. Nice seeing you here. Thank you very much. I will hand over to Dr. Charmi for any closing remark, please.
Yes. So thank you so much. It was a wonderful session. So we thank Dr. Antonio for his wonderful presentation, and the audience have messaged us that they really liked the studies, the data that you shared. It was very valuable. So we thank you for your time. And we also thank Dr. Arpandev Bhattacharya, sir, for his excellent moderation and taking out time and discussing important questions. And I'm sure the audience would have benefited from this. And we also thank our audience for their patient listening. And I'm sure it would highly benefit them in their clinical practice. And last but not the least, our technical partner, DocMo team, for arranging this and a smooth streaming of this session. So we thank you all. Have a wonderful day ahead.
Thank you very much. Thank you.
Thank you, sir.